So good afternoon or good morning to you folks. Welcome to today's session, New PrEP Guidelines, Systems for Level Reforms to Maximize PrEP. My name is Elizabeth Breidenbach. I'm a meeting and events specialist based in the Clinical Affairs Division here at NAC, and I'm pleased to bring you this event along with my division colleagues. Before we get started, I would like to review a few housekeeping announcements. You've joined this online event by physically calling in or using computer audio. All attendee lines have been muted and will be muted for the duration of this event. The duration of this live event is approximately 60 minutes, including introductions, presentations, and Q&A. Again, the duration of this live recorded event is 60 minutes, including introductions, presentations, and Q&A. We do have the Q&A box located in the lower right-hand side of your computer screen. I'm sorry, the chat box, my apologies. It's located in the lower right-hand side of your computer screen. Simply type your comments, questions, or concerns into this box at any time, selecting the to everyone during that drop-down panel to submit that information. And as a friendly little icebreaker I like to use, so I know that everybody knows where the chat box is at, please let us know in the chat box, where are you coming from today? What state are you coming from? Maybe you want to drop your health center's name in there. Let us know where you're working from today. We'd love to see from you in that chat box right now. Again, simply type that in and select the to everyone in that section and hit enter. Friendly reminders that today's event is being recorded. All attendee lines have been muted and will be muted for the duration of this event. Chat box is open and I can see people starting to pop things into there. Thank you so much. We're looking forward to reading those and reading your questions later on throughout today's session. And again, like I said, questions from the chat box. If we cannot answer questions in the time allotted, we'll make an attempt after the event has been completed. At this moment, I'm going to turn things over to Pedro, who's going to be introducing today's presenter and setting the stage. The floor is yours, Pedro. Thanks.
Hey, thank you so much, Liz. Hi, everybody. I'm Pedro Carneiro. I'm from the informatics team here at NAC, and we are getting started with our series on PrEP, HIV prevention, and new PrEP guidelines. I just want to put a plug for an upcoming event that we have on the 19th at 3 p.m. Eastern with Dr. Dimitri Daskalakis. And today's event, which is kicking off sort of this series, we have Amy Kilelea. She is a policy expert, and she's been leading a lot of the efforts into overhauling our HIV prevention system and increasing provision of PrEP. As everybody knows, there are new PrEP guidelines that came out, and they add a series of new types and modalities of PrEP that, while they're great to our communities, they need to be thought through and implemented successfully so that we don't commit sort of the sins of our past, right? And promote this continued disparities and inequities in healthcare. So I'm happy that we have her here. Amy, thank you so much. We're looking forward to your presentation. And I'll let you take it from here. And please let us know how folks should, they should just type questions and you feel free to answer any time, or do you prefer to answer all at the end? Just let us know how you feel about that. And thank you, and take it from here.
Terrific. Thank you, Pedro, and good afternoon, everyone. Thanks so much for having me today. This is a big topic. It's one we could spend many hours talking about. So we're going to get but a glimpse into the complex world of PrEP. And to Pedro's question to me and to all of you, what I'm going to do, you see here the roadmap for what we'll cover today, and I will just sort of pause after each section. So if you want to type in questions to the chat as we go, we'll sort of pause and try to take at least a few questions as we go, and then I'll leave a few minutes at the end as well. But there's just me as presenter today, so we can break up the sound of my voice as much as we can. So here's what's on tap for our time. I'm going to start out with a rundown of what's new in the PrEP space, including some of the newer medications that have come online, been approved by the FDA in the past 12 months. And then, as Pedro referenced, the new CDC guidelines that came out last year for PrEP. Then I want to walk through some of the statistics on PrEP access in the US and what that looks like. And then I'll spend the bulk of our time, or a good chunk of our time, really thinking through, talking through our financing system for PrEP, how it works right now, where some of the most glaring gaps in that system are. And then I'll end with some of the movement in federal spaces around a national PrEP program. So that is our sort of tall order of topics, and we'll get right to it. So first, I want to go through what is new for PrEP. The PrEP medication landscape has been really dynamic, a lot of changes within the market, and we're going to continue to see changes, I think. So let's start with the oral regimens for PrEP, so the once daily pills that are taken regularly to prevent HIV. Right now, we have two formulations of oral PrEP on the market. The first is TDF-FTC, that's sold under the brand name Truvada, and that's made by Gilead Sciences. This one was first approved for a PrEP indication by the FDA back in 2012. So we're actually approaching the decade anniversary of that first approval. This version of PrEP, TDF-FTC, is actually the only version of PrEP that has a generic option available right now, with about 11 manufacturers selling generic versions of TDF-FTC. Next, the next oral medication for PrEP is TAF-FTC. So that is a slightly different formulation than TDF-FTC. It is marketed under the brand name Descovy, and it's also manufactured by Gilead Sciences. One important difference to note, we're going to talk through a little bit the TDF-FTC versus TAF-FTC debate as we go, but one important distinction in terms of the FDA label is that Descovy has a slightly more narrow label than TDF-FTC. Descovy is not currently indicated for cisgender women, so that's important. Hopefully that will change, but that change is pending more data on this population that was not included in the approval, the first approval for Descovy. There is not yet a generic for this product. This was only approved in 2019 for PrEP, so we are in sort of early days there. And then finally, and this is the sort of newest of the PrEP landscape, in addition to the oral pill-based regimens we just talked about, we now have a long-acting injectable product for PrEP, long-acting injectable cabotegravir. That's sold under the brand name Apretude by ViiV Healthcare. This was sort of hot off the presses a bit, well, 6 months, I guess, but it's lots happened in that 6 months. It was approved back in December by the FDA. And this is administered a bit differently than oral medications. It's administered via intramuscular injection every 2 months. So this is important. It's not a self-injection product. So if folks are familiar with Cabenuva, which is a slightly different formulation, but a similar principle, it is the long-acting ARV, also made by ViiV for HIV treatment. Both of the administration routes, they're intramuscular injection, so it's not a self-injection product. And what's important about that is that you need a healthcare provider to administer the injection. So it's a bit more complex in terms of the administration route than the oral pill regimens. And I would just say, I mean, if folks, and this is not a presentation about the long-acting injectable on the HIV treatment side, but when you think about the HIV prevention infrastructure as compared to the HIV care and treatment infrastructure, just multiply the administration challenges for a product that has to be administered by a provider by like tenfold. It is an infrastructure that I think is still trying to get its head around biomedical prevention. And so the long-acting product, I think, is exciting, but also adds some challenges in terms of administration and implementation. This was just approved in December, as I said, so a generic is a long way off. And the only other thing that I'll say about all of these products, which is an exciting place to be in, is that they're all incredibly effective. The efficacy of every single one of these products is very, very high in both sexual transmission and transmission by injection drug use when we're talking about TDF-FTC and TAF-FTC in particular, at least in clinical trial settings. In clinical and real world settings. But what I want to note about long-acting cabotegravir is that looking just at the clinical trial data, because we don't have a lot of real world data yet, in the clinical trial data, the product resulted in a greater ability to avert HIV acquisition, most likely because of increased adherence. So you actually had superior results as compared to TDF-FTC, which was sort of the comparator arm in those clinical trials. So that's a new development. That's exciting. And again, we're going to have to figure out some of the challenges of implementation of a long-acting injectable product. And we aren't stopping there. There are multiple products in the PrEP development pipeline, some of which are on shorter timelines than others. The chart you have here in front of you is developed by AVAC, and it is updated frequently. So they are just an excellent resource to follow the latest news on what's being developed in the HIV prevention and vaccine space, and sort of up to the second news about where clinical trials stand and where different both U.S. and in the global space regulatory approvals. Some of the things to note here: the vaginal ring was under consideration by the FDA late last year, but the manufacturer pulled its application after it became clear that the FDA was just not inclined to approve it. So that is a product that is available in other countries, but not currently available in the U.S. And we'll see if that changes. There's been some advocacy around that, at least having that option open for folks. We've got oral long-acting PrEP in the pipeline. There are a few clinical trials that are on hold right now, pending some adverse events, and the hope is that those issues will get worked out and those clinical trials will get going again. But again, that would sort of be a long-acting result, but with a pill-based regimen, which sort of gets at some of the administration complexities with the long-acting injectable. We also have new products in the long-acting injectable space for PrEP, potentially with even longer intervals. Right now, it's a 2-month interval for the long-acting cabotegravir, but you could see even longer intervals between when people actually need injections, which again sort of makes it easier on the provider and on the consumer to access that product. So lots going on. This is a dynamic space, and I think we'll see over the coming couple of years, more movement in this research and development, and hopefully products being brought to market. So, with all of this sort of flux in the PrEP medication space, for a long time now, the CDC has really been under pressure to revise what quickly became outdated recommendations that were from 2017. And so that happened last year. Last year was a banner year for movement on the PrEP front, including with released revised guidelines from the CDC. I'm not going to go through all of the changes in those guidelines. I would direct you to go to the guidelines themselves. There's a great summary of the key pieces that changed at the beginning, but I want to highlight just a few of the really big ones. So first, and this is of no surprise, this was sort of like the hottest thing that needed to change. The CDC incorporated guidance for providers specifically around long-acting cabotegravir. Even though long-acting cabotegravir had not been approved by the FDA when the guidelines came out, CDC put in a lot of great information for providers in anticipation that, based on the clinical trial results, that would be approved, and it was. And there are also more guidance on Descovy, TAF, FTC, which at the time of the last publication of guidelines was not yet approved by the FDA. There was really only TDF FTC that was approved. So those were some of the bigger medication changes in the guidelines. And then we also saw changes to the PrEP monitoring guidelines. So the labs for ongoing monitoring at different intervals. Some of the labs are going to be at initiation in every 3 months, and then some of the labs and monitoring is now moving to 6 months or 12 months. So it's really it looks a bit more nuanced than it did in the first set of CDC guidelines. A few changes in particular to the monitoring. So one, an HIV RNA test is required at every interval. That's new. I know that has been a challenge for some providers and particularly labs trying to bill and get paid for that service. But that is one that is new. And then there's a change to the metabolic panel. So it is now recommended at an interval of every 12 months for persons who are under 50 and who had a normal panel at initiation, and then every 6 months for all other patients. So this is new, and I think this was a welcome change. It follows very much the WHO guidelines. in terms of not having a one-size-fits-all metabolic screening recommendation and trying to more tailor it to the needs of particular populations. So next, in terms of screening for PrEP and sort of PrEP indication and HIV risk, the new guidance, I think, does a really good job, sort of editorializing my own thoughts about the guidance, but I think does a really good job on having a more practical and pragmatic approach to provider screening and really opening up the indication for PrEP in just a more practical way that allows a wider swath of folks who could benefit from PrEP to get screened and identified and offered PrEP early. I think that's been really, really important considering some of the provider barriers to knowing about and being willing to prescribe PrEP. So this was, I think, makes it a little bit simpler for providers to adopt PrEP into their practice. So those were some really good changes on there. And then finally, the guidelines also provide more information on off-label prescribing for just for TDF-FTC for event-driven PrEP, and again for men who have sex with men. So this is like there's only a smaller subset of population and of PrEP medications that have been studied for on-demand PrEP. So it's a little bit more limited, but I think it does open up some more avenues for PrEP. So this event-driven PrEP is also called 211 PrEP or on-demand PrEP. It involves taking 2 pills 2 to 24 hours before sex, 1 pill 24 hours after the first dose, and 1 pill 24 hours after the second dose. So it's something that actually many state health departments have released their own guidance for how to prescribe PrEP in this manner. And I think from a consumer and a provider perspective, it opens up more options for patients to utilize PrEP in ways that are still safe and effective. So there have been clinical studies on this, even though it is not on the FDA label right now, but work better for someone's life. So that was new and I think important addition to the guidelines. All right, so with that as some of the major things that are moving, let me pause first and see any questions, Pedro, from the chat?
Yes. There's one that just came in. Is injectable cabotegravir twice monthly as shown on the slide, or bi-monthly as stated in the presentation?
Oh, and I am sorry.
Understood. Yeah.
Yeah, no, this could have absolutely been working too fast on the language on the slide. It is every 2 months. So it was as stated as bi-monthly every 2 months, not twice a month. If that was what on the slide, we will fix that before that goes out, and I apologize for that. But so it is clear for the record and for this recording, long-acting cabotegravir is available every 2 months. I'm glad that you raised that, and we will make sure that is correct. Okay.
Yep.
All right. Well, then we're going to move into a quick review on where we are in PrEP access in the U.S. And not to sort of jump to the conclusion, but it's not a great place. So we'll start with this graphic that is routinely updated by the CDC and really shows where we are on PrEP access in relation to the Ending the HIV Epidemic national goals. So as you all know, we are in the midst of a national federal initiative to end the HIV epidemic initiative with ambitious goals, a commitment to drastically reducing new HIV infections by 2030. And within that, there are metrics for PrEP access as well. And so by 2030, the U.S. is the metric that we set for ourselves is to be providing PrEP to 50% of those who are indicated for it. So as you can see by this graphic in front of you, we're pretty way off from that goal, and this is based on 2020 data released by CDC. And part of the reason for that too, you see that we're not way off from the goal for everybody. I mean, 25% is a fairly low number in terms of the 1.1 million people who could benefit from PrEP. 25% actually have a prescription. So that number is low, and it's lower than the 50% target. But when we drill down into different demographic groups, I think we see that widening and really marked disparities in who is accessing PrEP. And this has been the case, essentially from the very first product being introduced for PrEP in 2012. So, just to sort of drill down into some of these numbers, you see on the orange piece of the graph, 66% of white individuals who had an indication for PrEP were prescribed PrEP. And when we compare that first to Hispanic Latino folks, 16% of those folks who have an indication for PrEP are actually on it, and only 9% of Black or African American individuals with a PrEP indication were prescribed PrEP. So these are jarring statistics. I mean, this is really, I think, one of the most sort of visual ways to know, that the PrEP system in this country is not working for folks who could benefit from PrEP most. And this chart is this is 2019 data, so it is 1 year dated from the 2020 data, which is why the numbers are a little bit different. But I wanted to provide this to you as well, because you can see that, yes, there are racial and ethnic disparities, but there are also disparities among women and based on age. And I think that's important, particularly, we see a lot of provider education and awareness among women who could benefit from PrEP, and that the numbers do play out. There are increasing and pretty marked disparities between men and women accessing PrEP. And then, another factor here, and there are many factors, but I think geography is an important one too. In the South, in particular, we know that, more than half of new HIV cases are in the South. And yet we see that PrEP access really lags in the South behind other areas of the country. So, geographic disparities are also something that's important. And, though this is mostly in the South, I just sort of want to name it, the decision to expand or not to expand Medicaid under the ACA is one of those sort of X factors that it plays a big role in PrEP access. And this is actually fairly new data released by CDC, and it's on the social determinants of health. And I'm including it here because I really think it connects the systems at play in PrEP access and then actual access. So this chart, this series of charts, it's a little wonky, but breaking it down, what it essentially tells us is that if we looked at census data and we physically moved folks who live in zip codes with high uninsured rates to zip codes with low uninsured rates, that change would have a significant impact on PrEP access. So that alone, I think, really, combined with the geographic disparities that I just showed, I think it does sort of point to that we've got a systems set of challenges when it comes to PrEP, and we need a systems set of solutions. And I want to note, this doesn't account for confounding variables, of which there are likely many when we talk about the differences between states with low uninsured rates versus states with high uninsured rates. But I do think it is telling you a story, and it is painting a pretty compelling picture of the systems at play here when it comes to PrEP access. So with that overview of who is and who is not, well, actually, let me pause first and just say, any questions come in from the chat? I'm just going to pause after every section just so I don't miss anything.
Amy, I was just wondering, one of the things when we talk about PrEP and insurance is that folks will say, well, but can't people get PrEP for free anyway? So can you just kind of explain a little bit more about what the problem with the access and the insurance?
Yeah, I think that's a really good question. So for insured folks, there have been some success in PrEP coverage. So the U.S. Preventative Services Task Force, so that is an independent body that reviews clinical evidence associated with prevention interventions, and then gives each intervention a grade. And any intervention that gets a grade A or B, because of the ACA, there is an automatic requirement for the vast majority of private insurance plans, as well as Medicaid expansion programs, to cover that service without cost sharing. So in 2019, PrEP got a USPSTF grade A, and that was huge. And then plans had a year from that date to sort of get their act together and adopt that USPSTF grade for their coverage and cost sharing requirements. So it is true that we have like a good legal footing to say that most private insurance funds, they have to cover PrEP and they have to cover it without cost sharing. Now, as everybody knows, there's a lot of daylight sometimes between good legal footing and the actual reality of our healthcare system. So even with that legal footing, and even we got some good guidance from the federal government that even specified, PrEP isn't just a medication. PrEP is labs. PrEP are ancillary services. You got to cover all of it without cost sharing. Even then, we see a lot of discrepancies in what plans are doing, the extent to which those requirements are being complied with, and the extent to which state and federal regulators are enforcing those requirements. So I don't want to paint a sort of Pollyanna picture. If you just looked on the books, you'd say like, yeah, the law is there and it's clear and that's great. Like this shouldn't be a problem, and it's still a problem. I think we're going to have to continue on that implementing those coverage and cost sharing requirements, and then we have this sort of conundrum of how does long-acting cabotegravir fit into that? That was approved after the USPSTF recommendation. So everybody's sort of scratching their heads of sort of if that has to be covered without cost sharing, if we have to wait for the USPSTF recommendation to be updated. So it's a little messy, and we've got really good protections on the books, and then I think there's still a lot of work to be done to actually enforce those protections in ways that are meaningful for consumers.
And then somebody put it on the chat, which I think it's a problem that at least at NAC, we know health centers deal a lot with, which is the struggling with coding for, in this case, they say follow-up testing, but just in general, sometimes there's no coding and billing and structure set up for centers to also do the delivery of the service, right? So I think any pushback pushes the person out of the system, unfortunately, right? So thank you. And I just wanted to mention the comment on the...
Yeah, thank you for bringing up coding. And that's really important. It is like wonky, but it is a real barrier. I mean, we are hearing, so the piece that I think is the hardest nut to crack are covering the labs without cost sharing. I work with a lot of consumers who are fighting the cost sharing they're getting erroneously charged by their plans, and every single person I'm working with, it is labs that they're getting cost sharing for, and it's usually from one of like the big lab players like LabCorp or Quest. And I don't think necessarily it's LabCorp doesn't care about PrEP or people who need PrEP. I do think sometimes it is an administration issue where it's tricky. There are modifiers to mark an ACA preventative service, but if you have an HIV test, sometimes it's a USPSTF preventative service because it's a screen, and like that only has to be provided once per year. And then sometimes it's a USPSTF preventative services for PrEP, and then you have to have access to that without cost sharing multiple times a year. So I want to note, like, I do actually think the coding piece is a conundrum, but I think we got to figure out a path forward. Like LabCorp is real big, and I feel like there should be ways to identify appropriate coding practices, and we're in conversation with LabCorp and others to try to do just that. But I appreciate that you named that, because I do think that is a barrier right now for sure.
Great. We love to work with you on that, so stay connected.
Awesome. Well, this was actually a really good segue into talking about some of the systems pieces, the financing systems for PrEP, and I want to note, I'm focused on systems and financing, but I do think it's important just to sort of underscore there are many reasons for low PrEP uptake and for those alarming disparities that we see across groups. Some of them are very much stigma related. Some of them are provider education. There is not enough in terms of demand generation for PrEP. There's a whole host of structural barriers that I think are important to consider. And I think also that the system that we have built for PrEP financing and delivery is fundamentally fragmented and fundamentally sort of gap-filled and incomplete. And so, I contend that is a large driver, not the only driver, but a large driver in low PrEP uptake in this country and the growing disparities in PrEP. And so I want to walk through a little bit of this. So, and I just walked through some of the pieces for the insured. So I'm going to sort of leave that. We've got some wins when it comes to insured folks in PrEP access, and then we've got some roads still to walk on that. And I want to focus a minute on the uninsured, because I think that's where we really see some of the ways that the fragmentation of our system sort of plays out in consumer access. The fact that brand name products were so expensive when they were first rolled out. So, when Truvada was first approved for PrEP back in 2012 and up till today, high list price tag. Descovy, same thing. Long-acting cabotegravir, $22,500 per year. So we've got high list prices for these, and I do want to note that the fact that we had such a high price tag when they were first rolled out really put manufacturer assistance programs at the center of our approach to PrEP. Now, again, not the only piece. Certainly, community health centers and 340B entities play a role too, but we really did sort of put a whole lot of pressure on manufacturer assistance programs. And that really hasn't changed all that much for uninsured folks, even with generics. And we'll talk about that in a little bit more detail. But what that has meant, the fact that we sort of center manufacturer assistance programs as the sort of core source of medication access for uninsured folks, is that we have really needed and we have created a patchwork from the get-go, because manufacturer assistance programs and even the Ready Set PrEP donation program only provide access to the drug. They don't provide access to labs or any other PrEP ancillary services. So right off the bat, you sort of create one program that covers the medication, but then we know you can't get PrEP without getting the requisite labs. So then you have to create another program that handles the labs, and sometimes even another program that is going to handle the clinical visit and or outreach and adherence and counseling and linkage services that come with PrEP. So you just have a patchwork that in and of itself is burdensome to navigate, and it creates a whole lot of gaps and holes in its wake. And there's just no one program, and that's why sort of I divide and created this chart to sort of visually show you. It is like a series of like buckets that we divide out each element of PrEP. There's no one program in this country that covers all of them. And why does this matter? And I think sometimes it's easy to get lost in sort of the policy weeds of it all, and what we see on paper in terms of the statistics and the programmatic pieces. So I just wanted to take a moment and just note some direct consumer feedback that we got, and this was from a series of consumer focus groups that Johns Hopkins University did as part of a project that I'm going to talk about in a little bit, to develop a proposal for a national PrEP program. So as part of that project, the team brought together a series of folks, or a series of focus groups, including folks who were on PrEP or were not on PrEP but had challenges accessing PrEP. So some of the things that we heard from that, and number one, and I think this was really telling, it's kind of expensive for a disease I don't have. And this, I think, is really like encapsulates that the accessing a prevention intervention is very different than accessing an ARV for treatment. That, particularly when we put up all of these hoops for, you got to go through the manufacturer assistance program, and then you got to, recertify your income at these intervals, and then you got to go to this other program to access these other services. For someone who does not have a diagnosis, who doesn't have a condition that they're sort of compelled to go get treatment for regularly, it's a different calculus. It's a different set of, I think, barriers that are put in place, and we don't have enough sort of low threshold ways to get access to PrEP, especially for uninsured folks. The related comment, I stopped using PrEP because it became too much of a hassle to keep verifying my information every month, that I didn't have a job, that I didn't have income, and it started making me feel bad. So again, like a very, very, sort of human face on how burdensome processes for application and renewal can impact actual access to those programs. And then, and I think there are many, folks on the line who come from and who lead LGBT focused health clinics. So you are probably well familiar with this, of why people go to you. But this person, I go to an LGBT health clinic for my PrEP because primary care doctors really don't know anything about PrEP. So finding providers, whether it's through a health clinic or another venue, who know about PrEP, who understand it, and who aren't going to be stigmatizing for folks, was also something that came up a lot in the focus groups. So I want to come back, sort of circle back to a point that I raised in talking about the fragmented system, because this is actually one where, and I'd be happy to for folks to disagree with me on this, because I'm always curious as to what people think, especially you all coming from the community health center world and vantage point. But many people sort of could contend, right, that for PrEP, the drug is available for free through manufacturer assistance programs and through Ready Set PrEP. Price is an issue, or we have generics, so price isn't the issue. And I think my response is to say that price is an issue. Price has really helped set the course for this fragmented and fairly incomplete and really non-public health response when it comes to PrEP. There is really no other reason aside from the high price of the drug that we rely on these manufacturer and donation programs that separate out that drug from other PrEP services. Aside from the price of the drug, there's really no other reason that CDC has these long-standing restrictions on using grant funds to pay for the drug. That's not statute like it is for the Ryan White program. That is a CDC policy decision. I just wanted to note that manufacturers, they are and they have been essential public health partners. But I think in many ways, because we've had such gaps in public health infrastructure in access to PrEP, we've really sort of propped up manufacturers as a stand-in for public health systems, and kind of required them to be. And that I think they have been and should be a safety net, but we need to sort of look beyond that system for financing PrEP at other ways that we could do it. And the other piece on generics, and I think this is very interesting because if you had me here a year ago, I would have said we are on the precipice of something big, because we had just seen that Teva, which was the first pharmaceutical approved to offer generic TFFTC, their 6-month exclusivity period was just coming to an end, or had just ended, I think, in April of last year. And so then you had all of these other manufacturers who were ready and who started to offer PrEP, and the price plummeted, right? The price of generic TFFTC just it kept going down, 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 down. And now, it's like at 78 cents a pill, because you've got all of this competition. So it's like dirt cheap, and it's super effective, and it's super safe. So if you had asked me a year ago, I would have said, here's the turning point, guys. We are going to open the floodgates and get generic TFTC out to everybody. And it just did not happen. It did not happen. It's still not happening. Now we're a year into multi-generic competition for PrEP. And so it should have been a turning point, and it wasn't. And why is that? And I think many reasons, but largely I think it's because we have this broken and limited system that we've built for PrEP that incentivizes brand name drugs at every turn. I think one way that we can sort of see the thumb on the scale of brand name drugs is just looking at prescriber data. And you could do this, this is from CROI. I thought this was a great sort of depiction and set of data that really shows the differences and the upticks in TAF prescribing and TDF-FTC prescribing. You can also look at Gilead shareholder reports where they report on the market that they're still retaining for Descovy, despite the availability of generic TFTC. So, and you can look at, I've also seen data coming out of individual clinics that show prescribing patterns. So I think that they're not everywhere, but there is a trend that Descovy is being prescribed in some cases over to the FTC, not because it's better or clinically indicated for most people. I think we have an overwhelming set of evidence that it's really not. It may be better for a small subset, but for the majority of people, TDF-FTC is really the appropriate regimen to start on. And I think one of the main reasons is that we've created this broken system for PrEP that makes it so prescribing a high cost drug that people don't need to generate 340B revenue is one of the only ways to fund a PrEP program. And I want to, I'm going to skip around just for 1 second because I want to talk about 340B for a minute. And really, we can't talk about PrEP financing and systems of PrEP financing without talking about 340B. It's sort of the elephant in the room. And I think number one, generic competition, just as it exists, just by virtue of how 340B revenue generation works, which I know you all are well familiar with, so I'm not going to go into that. Generic competition threatens that revenue, and it's likely one of the drivers of an inflated market for Descovy. On the 340B space, we also see a lot of flux and instability in that system, particularly with the Gilead deciding to end its reimbursement practices for its advancing access, its manufacturer assistance programs, where it had been reimbursing at a much higher usual and customary price for 340B entities instead of acquisition costs, which it moved to in January. So you saw this is sort of like bubble burst in terms of the ability of 340B entities to generate revenue from the Gilead Advancing Access Program and reinvest it into programs that really were in dire need of that type of funding. And then we just see these like global challenges, which I know NAC is very much involved in terms of manufacturers challenging the breadth and scope of 340B writ large, including contract pharmacies. So I think the takeaway here is that 340, there's a fundamental instability in relying so heavily on 340B revenue to fund a public health response to PrEP. And I think we're grappling with that right now, especially with the advancing access changes that for many entities, there is a little bit of a sort of reckoning of if the 340B revenue is not cannot be the only source of funding that is supporting PrEP access, what does a sustainable path look like forward? And so I'm actually going to move to that now because I could end there and then it would be sort of a downer. But I do want to talk about some of the national conversations to address some of these systems challenges that I've noted and where some of these are headed or could head. But let me pause. I just covered a lot of financing ground, so I just want to pause for a moment and see if there are any questions on that.
Yeah. So Amy, Adam made a great question. Had a great question about financing for PrEP and really how your thoughts on reducing our reliance on this kind of like charitable manufacturer program that really is just kind of like a band-aid, right, for our lack of safety net in many ways.
Yeah, it's a great segue into talking about this national PrEP program. But I would just note, I mean, I think it's like it's because I don't want to shortchange the manufacturer assistance programs. Like they have been a lifeline, and that is they have provided PrEP to a lot of people who would not otherwise be able to access it. So I think that they've played a role. And I think that we really have not had a full-throated public health response to PrEP for many reasons. I mean, it sort of fell in this no man's land of the Ryan White program is a well-functioning, well-funded program that provides access to ARVs, but you have to have an HIV diagnosis to get access to the program. So like that was cut off. CDC is the HIV prevention program, right? Like it is the most practical sort of home for PrEP access. And, you have some real issues with that program funding clinical access, right? Biomedical prevention interventions. You can't use that funding to pay for the drug. And up until very recently, you couldn't use that funding for the most part to pay for labs. So you just had this like no man's land. So that was like why you had reliance on these manufacturer assistance programs. And now I think we're at this like inflection point of what do we do going forward? And so, you know, I'm going to talk now, and this was like a perfect segue, Adam, so thank you for that, about how we build up the public health infrastructure to function as a public health system for PrEP. And that is going to take reliance off the necessity of having this patchwork and manufacturer assistance programs and donation programs. So I think it is about building up the public health response to PrEP and you know, sort of taking off the pressure of relying solely on these manufacturer assistance programs. And side note, lower the prices. So I think that's really important. Price is one of the main reasons why we are so reliant on manufacturer assistance programs. If the drugs were not so expensive, we would not need to rely so heavily on manufacturer assistance programs. So I'm going to get into that in one moment here. All right, so we've had some exciting news in the past month. So this was exciting timing to have this presentation. We saw in the president's budget. So every year the president releases a budget. It's sort of a wish list, but it's a good indication of the administration's priorities when it comes to spending and programs. And so domestically, this was a really good indication of the administration's commitment to HIV and PrEP in particular. So what we saw is that we had this language that I've highlighted in front of you, a call in the president's budget to Congress to fund a national PrEP program, and a pretty significant call or commitment for funding of $9.8 billion over 10 years. So this was a sort of full-throated do PrEP differently in this country and do it through a national PrEP program. So the language included in the budget articulates a PrEP program for the un- and underinsured, and then coupled with significant reforms to Medicaid to really make Medicaid work better for PrEP. And I didn't talk so much about Medicaid, but I will just note there are access problems to PrEP through Medicaid, through a limited provider network, through limited coverage of labs in some cases. So, you know, I don't want to, Medicaid is incredibly important, and I think that there are ways that program can and should do better when it comes to PrEP. So you've got both of those components in this president's budget request. And, you know, the request, I think it comes after years of advocacy for a national PrEP program. And then I think what helped to sort of light the fire under it is a proposal that was put out by Johns Hopkins University. And I think you all should have a link to that, or we can share one. But a proposal put out by Johns Hopkins University that I helped to work on as well for a national PrEP program. And we released that in December. And some of the components of that proposal, in addition to folks at PrEP for All, a great national organization, have also been calling for a national PrEP program for years now. So you sort of had those efforts culminate in this president's budget request. Now, all that said is that you know, you've got like a foundation, but the language in the budget is very vague. So now we're at this point where like the rubber meets the road. Like, what are we going as a community? What is the HIV community going to ask Congress to do? And then what is Congress actually going to do when it comes to, you know, putting in legislative language and appropriations for a national PrEP program? But I want to note in the proposal that the Hopkins team released, and then in a sign-on letter that was signed on by 25, I think, national HIV organizations. You know, I think that there is a slow but sure consensus building around what a foundation for a national PrEP program could look like. And you see some of those, the principles there in front of you. It's got to be accessible. It's got to be simple. You know, you can't drown people in paperwork for disease they don't have. It's got to be affordable. It's got to be sustainable. And that piece I'm going to talk about in a minute, because that's important for scale and scope. We are throwing money away right now, and we will never get the scale and scope unless we have a more efficient approach to PrEP. It's got to be equitable. It's got to recognize that we have fundamental flaws in how we are financing and delivering PrEP that are causing these growing disparities. And then it's going to be adaptable. I said at the outset, PrEP is dynamic, and it's just going to continue to be so. So we need a program that is able to roll with those changes in PrEP. And so, as I said, we're not building from scratch here. These were the components of the proposal that I referenced from Hopkins, and I think this helped influence the budget request. And this proposal, it's a jumping off place. It's not an end place, but I do think it adds some important ideas to the mix for what elements are needed for true systems reforms, and including the three that you see in front of you. And I'm just going to walk through these very quickly, so we still have a few minutes at the end for questions. The first part is a way for the federal government to negotiate fair public health prices. And here I have for medications, and I would also add for labs as well. I think medications is the biggest nut to crack, but labs as well. We know that labs and the charges for labs vary by geography, by clinic, by relationship with payer. And so we think that's important as well. But a core element of the program would be a streamlined federal negotiation for the price of PrEP medications for a national PrEP program. And this would include generic to the FDC. That's already sort of dirt cheap, but I think the opportunity would be to build infrastructure to negotiate for fair public health prices for the other brand name products, including long-acting cabotegravir and the brand name products coming down the pike. And so this is important. I think this is to Adam's question, sort of a way to take us away from this over-reliance on manufacturer assistance programs and/or donation programs, and really build up an infrastructure that's able to sustainably provide access to PrEP. The other piece is that there could be like two ways to do this. You could reimburse pharmacies at the negotiated federal rate, and that way you're using existing procurement processes. Or you also could have a similar mechanism to how the Vaccines for Children program works now, where you allow sites that are able to and want to order PrEP and distribute PrEP on site in their clinic. And so both of those options would be possible. And again, this would be mostly for the uninsured, although I think there may be an element for Medicaid here too. So we're not talking about drug prices for commercial insurance or Medicare. We're really talking about uninsured primarily, and possibly also Medicaid. This next part, options for as I said, for clinical sites to provide on-site dispensing. And then, importantly, the lab services too. So, clinicians should be able to access lab services for patients who don't now have a source of payment. And that could be through a federal contract with a network of national labs. It also could be through a federal reimbursement mechanism for lab services. There are a bunch of different ways to do it, but I think the recognition here is that lab services have to be a part of the program. And again, for uninsured people and people who do not have a ready source of payment for labs. And then finally, and I think this is the most important part, the third part of the proposal really does envision a much broader network of providers who are able to distribute PrEP. And this would build off of the CDC HIV prevention grantees, include outreach programs, mobile prevention units, domestic violence shelters, drug treatment centers, and others. And this is really meant to work hand in hand with the work that community health centers are doing, that other clinical providers are doing, and just broaden the scope of providers, some of whom are going to be in a better position to reach folks who, for whatever reason, are not walking into a community health center or clinical setting. And I think we saw that in the COVID vaccine messaging and distribution and consumer education space, that there were some that getting out into communities via different non-traditional networks was really, really effective. One way to engage non-traditional providers who don't have a clinical prescriber on site would be to build up capacity for telehealth, and could involve connecting that non-traditional provider network with community health center or other sort of clinical prescriber hubs that provide that clinical prescriber and expertise via telehealth. I think that in addition to that, we need more. So we need the national PrEP program, and then an array of capacity building assistance, continued investment in community health centers, increased CDC HIV prevention funding. It is really a sort of multi-pronged approach, but we won't get there without having that multi-pronged approach, and especially consumer and provider education efforts too. So what I'm going to end with, and then open up our remaining minutes to any questions, is that to come back to efficiency and sustainability, I think we have a lot of choices, and we have some opportunities in front of us, but I really do believe that the scale and scope is predicated on a more efficient use of resources. So when we talk about fair public health prices, it's not just sort of fair public health prices for an ideological reason, or for fair public health prices just for the sake of them. It really is to make sure that we're preserving enough funds for all of the other stuff that we know is essential to PrEP access. And so we won't be able to, if we have a national PrEP program, and even with $1 billion a year, if we don't get down the price of drugs, and we try to then expand the providers who are able to purchase and distribute drugs outside the 340B system, we'll go bankrupt. I mean, that program will not go very far. But if we can get those prices down, similar to what the AIDS Drug Assistance Program is able to do on the HIV treatment side, I think it opens us up for use of funds in a really innovative and creative and far more widespread way. So I'm going to end there, and you've got the link to the proposal that I mentioned, and then my contact information. So feel free to contact me, and I will turn it to you, Pedro, if there are any questions.
Thank you so much, Amy. Well, no questions. Just wanted to, so far. Feel free, folks, to jump in. I just wanted to thank you, and also really highlight the point that you made at the end. I think it's a very important one around, the wraparound and the multi kind of team dynamic that it takes to do PrEP. So sometimes we really focus on the actual intervention, that's the medication, but there's this whole system that needs to live around it. So I think that, if we think about how much, the medication costs versus how much money we put into the system to exist, we can see how that dynamic is totally off in terms of, how expensive one is versus how poor the other one is, right? A great point. Link for the proposal. So it was on the slide before, and we can also, are we going to be sharing slides, Liz? I'm not sure.
Yeah, we are going to be sharing the slides. I believe that it was hyperlinked, so we'll be able to share the slides with you, and again, it'll be hyperlinked, so then you'll be able to click directly on that PDF to go to the link to the proposal and any other active links that are in that PowerPoint.
Awesome. And I can just do this too.
And then Amy also put it in there. Make it easy. So just to be on time, I wanted to thank you, and until the next time, and everybody stick around and look, not stick around, but look for our series on HIV prevention. We have one on the 19th, and we'll have other ones coming up as well. Thank you, Amy.
Thank you. Bye, everyone.
Thanks.
Bye.
Bye.